So is it visible now?
Hello. Yeah, perfect. You can stop presenting so that I can present.
Yes, sir.
All set, should we start? Should we start? Should we start? Dr. Shristi, should we start?
Yes, sir.
Waiting for your. Okay, here we go. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 19B, which is Hematology, Malignant Myeloid Diseases. We are streaming live from IPGMER, Kolkata. And we have a very interesting introductory on a basic topic for today's discussion. And so the topic of the day is classification and clinical manifestations of clonal myeloid disorder, something which we all need to know before we step into the details of malignant myeloid diseases. And to speak on that, we have once again Dr. Shristi Butta. She is an MBBS Honors Gold Medalist, MD Pathology Honors. Presently, she is a demonstrator at the IPGMER and SSKM Hospital, Kolkata. Her areas of interest being cytopathology, hematopathology, and oncopathology. She has had taken quite a few lectures on this series, and they have been very well taken. She's a very nice speaker. She is very knowledgeable about the subject, and she presents the subject very well. Before I ask Dr. Butta to speak, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Butta, ma'am, please share your screen. Let's start.
Thank you so much, sir. It's a real honor, sir, to be a part of this series. I'll just share my screen.
You're absolutely fine. Please start.
Yes, sir. Thank you, sir. So, a very good evening. Today's lecture is on clonal myeloid neoplasms. It's one of the very important topics for all the postgraduate trainees. So, let's start. Before we start, I'd just like to say that WHO classification of tumors of hematopoietic and lymphoid tissues is one of the basic references of the seminar. So, clonal myeloid neoplasms, prior to the 1970s, lacked a uniform system for classification and nomenclature. It was the French, American, and British who, in the year 1976, came first with a FAB classification. Since then, there have been several classifications, of which 2001 WHO classification of tumors of hematopoietic and lymphoid tissues reflected a paradigm shift in our approach to the diagnosis of myeloid neoplasms. A greater effort was given to the genetic information of the myeloid neoplasms. The importance of careful clinical, morphological, and immunophenotypic characterization of every myeloid neoplasm and its correlation with genetic findings cannot be overemphasized. The most recent revision explicitly acknowledges the recurrent genetic abnormalities and the genetic and abnormal pathways involved in the classification of these tumors, and thereafter it allows for a better therapeutic target. So, coming to the overview of the seminar for today, WHO classifies myeloid neoplasms as myeloproliferative neoplasms, myeloid neoplasms associated with eosinophilia and gene rearrangements, myelodysplastic syndromes, MDS MPNs, and acute myeloid leukemias. The topic for discussion for today has been highlighted in red. Stress would be given on myeloproliferative neoplasms, myelodysplastic syndromes, and acute myeloid leukemia. Briefly, we would also discuss myelodysplastic syndrome and MPNs, that is MDS MPNs, and myeloid neoplasms with eosinophilia and gene rearrangement. So without much ado, let's start. MPN WHO 2017 classifies it as chronic myeloid leukemias, BCR-ABL1 positive, CNL, PV, ET, PMF, and the chronic eosinophilic leukemia, NOS, as well as the MPN unclassifiable. Now, the myeloproliferative neoplasms, these are clonal diseases arising from abnormal bone marrow stem cells. Even though one cell line may have a proliferative advantage in most diseases, all the myeloid lineages, remember all the myeloid lineages are derived from the same neoplastic clone. Proliferative advantage, though given to a single cell line. So if we are talking about chronic myeloid leukemia, that cell line would be granulocytic. If you're talking about Polycythemia vera, then that single cell line would be erythrocytic. On the other hand, when we're talking about ET, for example, it would be megakaryocytic. Even though the cell line would be one, the myeloid lineage cells would be derived from that neoplastic clone. Features like organomegaly, thrombocytosis, myelofibrosis would be commonly found. Progressive disease often terminates in the bone marrow, resulting in the blastic phase. Now, this chart is really very important because our seminar would be revolving around this chart. So just have a careful look. If the peripheral blood shows cytopenia or cytosis, and the bone marrow is either hypocellular or hypercellular for that matter, the blasts are either less than or equal to 19% or more than or equal to 20%, and the morphology of the cells is either normal or it's abnormal. So let's look at the first case scenario where the patient has peripheral blood showing cytosis. Yes, it's leukocytosis. Okay, there's a proliferation of the granulocytic cells. There's a hypercellular marrow, right? There's panmyelosis, myelofibrosis, may be associated. Blasts are usually about 2%, and the morphology of the cells is normal. So what do you think this case would be? Cytosis with a hypercellular marrow, approximately less than 10% blasts, okay, and a normal morphology of the cells. Chronic myeloid leukemia, the chronic phase, yes, the clonal disease that originates in a pluripotent bone marrow stem cell, often associated with BCR-ABL1 fusion gene. Okay, though there's another entity called as the atypical CML, which will be discussed in just a bit. Okay, neutrophilic leukocytosis is the major initial finding in this case. Okay, so you have a base BCR-ABL1, which is found in all myeloid lineages. Okay, and sometimes even in lymphocytes and endothelial cells. Okay, now what happens next is that this disease progresses from its chronic phase to the accelerated phase and then to the blast phase. Okay. It must also be noted that this chronic phase can itself change into the blast crisis. So let's look at the bone marrow biopsy of this case. You have a granulocytic proliferation, maturing granulocytes here. Okay, megakaryocytic proliferation. Look at these small megakaryocytes here. Okay, they are hyperlobated, small dwarf megakaryocytes. Okay, and there's an increase in the myeloid is to erythroid ratio. That is, the ME ratio is comparatively increased. So what's the diagnostic issue here? The diagnostic issue over here is this gene, that is the BCR-ABL1 gene, which is very important because that identifies the process to be neoplastic. It's nothing but the Philadelphia chromosome, and that suggests that the process is not reactive. Look at the peripheral blood picture here. There's leukocytosis, okay, with a spectrum of the granulocytic series cells here. Okay, there's even basophil here. Okay, so the basophilia is a very important feature of CML. Here again, we have a lot of megakaryocytic proliferation. These are small dwarf megakaryocytes. Okay, here. So what is the characteristic blood picture here? We have leukocytosis, basophilia. Note that there is no dysplasia. No dysplasia. That is, the morphology is absolutely normal. Okay, in the blood you have approximately less than 10% blasts. Okay, and there's positive Philadelphia chromosome, as we already said. Now, regarding the bone marrow is hypercellular. There's an increase in the ME ratio. There's minimal dysplasia. Okay, comparatively no dysplasia for that matter. And small megakaryocytes. There's an increase in megakaryocytic proliferation as well. Blasts are also less than 10%. So this is the chronic phase of CML. Now look at the spleen of this case. The spleen is enlarged due to the proliferation of the granulocytes and some megakaryocytes in the cords, as well as the cells passing through the sinuses. So that has resulted in this splenic infarct here. Okay, the pictures have been taken from the very nice seminar by Dr. K. Mirza of the College of American Pathology. This is some of the other pictures taken from the same seminar here. It's here, we have diffuse cords and sinuses, okay, here. And these sinuses have a lot of granulocytes, okay, and that has resulted in the splenic infarct. So as discussed, this chronic phase can progress from the chronic phase to the accelerated phase and subsequently to the blastic phase, okay? Or it can also progress from the chronic phase directly to the blastic phase. What about the accelerated phase? Now, the CML-AP has been defined by the presence of more than or equal to one of the hematologic or cytologic criteria. Okay, so what is the criteria there? It's a persistent or increasing white blood cell count which is unresponsive to therapy. Note, it is unresponsive to therapy. Persistent or increasing splenomegaly, thrombocytosis, thrombocytopenia, all unresponsive to therapy. Okay, even after giving a lot of TKIs, that is the imatinib, it is not responding. So if it's not responding to imatinib, what happens is that there is a progression from the chronic phase to the accelerated phase. Okay, the basophils have increased to about more than or equal to 20%. Blasts have increased from less than 10% to 10 to 19%. And additional clonal chromosomal abnormalities like a secondary Philadelphia trisomy 8, isochromosome 17q, and trisomy 19, or sometimes you may also have some complex karyotypes. Okay, so either more than or equal to one of these criteria must be fulfilled, or the provisional criteria. What is the provisional response criteria to TKI? That is the hematological resistance to the first TKI, any hematological or cytogenetic or molecular indication, and occurrence of 2 or more mutations in the BCR-ABL1 fusion gene during the TKI therapy. Okay. Now coming to the CML blast phase. CML. Now this is the blast phase of CML, which is characterized by a blast count of more than or equal to 20% in the blood and or the bone marrow. Earlier, the count was given to be 30%. However, it's been found that even with the blast count of 20%, the response is very poor. Okay, so making the blast phase with a blast count of more than or equal to 20% has now been given in the recent WHO. In addition, there is also extramedullary proliferation of blasts. There may also be large foci of blasts in the bone marrow biopsy. These blasts are about myeloid blasts in about 70 to 80% of the cases, lymphoid blasts in about 20 to 30% of the cases, and mixed phenotypic blasts, that is about 10% or more of the cases, are usually associated with both, that is myeloid as well as the lymphoid blasts. Now coming to the pathogenesis of MPNs, it's very important to note that either there is an increased proliferation or a decreased apoptosis. Okay, increased proliferation occurs basically due to constitutive activation of the tyrosine kinase receptors. Okay, now coming to a very important gene, that is the JAK2. It's a cytoplasmic protein tyrosine kinase which is bound to the cytoplasmic domain of a number of cytokine receptors, like the erythropoietin or the GM-CSF or the interleukin growth factor 1 or the interleukin 3 for that matter. What happens then? It is important to note that when this JAK2 binds to STAT, there is a JAK2 STAT pathway that is activated, or the JAK STAT pathway is activated, and that allows for increased nuclear transcription and subsequently an increase in the proliferation of the cells. If this pathway is constitutively activated, it allows for increased proliferation of either the granulocytic lineage or the erythrocytic lineage for that matter, or the megakaryocytic lineage for that matter. So it is the JAK-STAT pathway which is very important and implicated in the pathogenesis and proliferation of cells of the myeloid proliferative neoplasms. So the diagnostic issue here is either identifying a BCR-ABL1 for that matter in CML, or a JAK2V617F in PV and ET. Let's see other genes that are implicated or rearranged tyrosine kinase genes involved in myeloproliferative neoplasms. In CML, you have BCR-ABL1. Yes, we've already discussed this. In other myeloid neoplasms with eosinophilias, you have PDGFRA, okay, PDGFRB, FGFR1. In Polycythemia vera, we have JAK2V617F, most commonly mutated in approximately 80 to 90% of the cases. We also have the genes like MPL, okay, which is mutated in addition to JAK2V617F in PV and PMF. In mastocytosis, we have KIT mutations. Now coming to another case scenario. Now look at this. We have cytosis. Okay, the cytosis is basically in the erythrocytes, that is the RBCs. Okay, look at this. So there is increased cytosis in the peripheral blood, and you see that there is an increase in the erythrocytes, right? The bone marrow is hypercellular, okay, with panmyelosis. And you have a blast which is comparatively less than 10%. Okay, Okay, so this is the case scenario. The morphology of the cells is absolutely normal. So morphology of the cells are normal. You have a blast which is less than 10%, a hypercellular marrow, and a cytosis showing an increase in the erythrocytes. What do you think this case would be? It's a case of polycythemia vera. Now, polycythemia vera is a clonal myeloproliferative neoplasm which is characterized by increased RBC production. But note that this RBC production is not associated with increase in the erythropoietin levels. So there is a subnormal erythropoietin level in PV. Unlike the secondary causes of polycythemia, where there is an increase in the erythropoietin levels. So where does it arise from? It arises from the clonal hematopoietic stem cells. Okay, it is important to note that there is a panmyelosis. Panmyelosis in the bone marrow with increase in the granulocytic, erythroid, as well as megakaryocytic and even sometimes lymphocytic precursors. Now coming to the diagnostic criteria of polycythemia vera. The major criteria here is either an elevated hemoglobin, okay, that is more than 16.5 in males, more than 16 in females, or an elevated hematocrit, which is more than 49% in men, or more than 48% in women, or an increased red cell mass, okay, which is approximately more than 25% above the mean predicted value. So anyway, you must always know that there is an increase in the RBC, okay, there is an increase in the RBC, whether it is hemoglobin, hematocrit, or red cell mass, that has increased. Okay, so the RBCs have increased. Yes, bone marrow biopsy is showing a panmyelosis with hypercellularity. Okay, and there is a presence of JAK2V617F mutation. Okay, so the major criteria, either all the three are met or the first two is met. Okay, with the minor criteria. Okay, the minor criteria is only one. You have subnormal serum erythropoietin levels. So either 3 major or 2 major with minor allows for the diagnosis of polycythemia vera. Now look at this blood picture here. You have erythrocytosis in a 60-year-old male who presented with dizziness for 2 months. Okay, and a hemoglobin is about 20 grams per DL. Platelets have also increased, and increase in red cell mass is also noted. Okay, so what is typically very important is here, you see you have a lot of erythrocytes here. Okay, so this is one picture giving you a clue that you should go in for a bone marrow, and if the bone marrow reveals a panmyelosis with this picture together with JAK2V617F and a subnormal erythropoietin level, all indicating towards a polycythemia vera. The bone marrow is showing hypercellularity. Yes, there is panmyelosis. And look at these megakaryocytes here. These megakaryocytes are very classic here, present in small aggregates. Okay, small aggregates here. A lot of megakaryocytes all present in small aggregates. Here again, we have another picture. So the blood finding shows leukocytosis. Okay, so that may be neutrophils, basophils, there's thrombocytosis, the red blood cells are normocytic, normochromic, bone marrow is showing a panmyelosis with an increase in the erythroid and megakaryocytic proliferation, okay, and there is a stainable iron which is absent, okay. Reticulin fibers are normal to slightly increased. Now coming to the differential diagnosis of polycythemia vera, okay, this polycythemia vera must be distinguished from secondary polycythemias. Okay, secondary polycythemias, it is very important to differentiate it from secondary polycythemia. In addition, it should also be differentiated from other myeloproliferative neoplasms. Now, the secondary polycythemias are usually characterized by an elevated erythropoietin levels. Okay, so there is an elevated erythropoietin level. Okay, whereas in polycythemia vera, we've already discussed that there is a decreased erythropoietin level. Okay, JAK2V617F mutations are absent in case of secondary causes, whereas it is present in case of polycythemia vera. Right? Okay. Now coming to the post-polycythemic myelofibrosis. Now this is the secondary stage of polycythemia vera, where it is characterized by myelofibrosis. The myelofibrosis, all cases are characterized by leukoerythroblastic blood picture with teardrop cells, and RBCs are showing poikilocytosis, a marrow depletion with increased reticulin and collagen fibers. okay, and sometimes even osteosclerosis. The diagnostic criteria of post-polycythemia vera myelofibrosis has been given in WHO. Let's just see. The required criteria is documentation of polycythemia vera, okay, with marrow fibrosis. Additional criteria, two are required. Either it's anemia, leukoerythroblastic blood picture, increased splenomegaly, or any two of the three, that is more than 10% weight loss, night sweats, and unexplained fever. Coming to primary myelofibrosis. Now, this is a clonal myeloproliferative neoplasm, okay, which is characterized by proliferation of granulocytes as well as megakaryocytes. So, are you noting one very important thing? There is proliferation of granulocytes with megakaryocytes, granulocytes with RBCs, and RBCs and megakaryocytes. So, in all the cases, we are having what is called as pan-myelosis. Okay, so there is a pan-myelosis happening, even though the clonal component involved is either a granulocyte, RBC, or a megakaryocyte, but there is a pan-myelosis happening in the bone marrow. Okay. Together with that, there may be extramedullary hematopoiesis, and about 50% of the cases have JAK2 mutations. Okay. And another mutation which is often associated with the PMF is the MPL. Now, coming to the pre-fibrotic stage. Now, the pre-fibrotic stage, here you have a lot of megakaryocytes here. Okay, look at these megakaryocytes and granulocytes. And in the fibrotic stage, what you have is a lot of fibrosis here. Okay, let's see the diagnostic criteria. We have also sinusoidal hematopoiesis noted in PMF. Now, coming to the diagnostic criteria of primary myelofibrosis, there is megakaryocytic proliferation, as has been already illustrated, okay, with atypia, without reticulin fibrosis. Okay, so there is megakaryocytic proliferation and atypia, but without reticulin fibrosis, and that is a pre-fibrotic stage. WHO criteria for BCR-ABL1 positive CML is not met. Mutations associated with either JAK2V617F, CALR, or MPL. Okay, so either it is all the three major criteria and at least one minor criteria. Okay, so it is very important that you have all the three major with at least one minor. What is the minor criteria? Anemia, leukocytosis, palpable splenomegaly, and a lactate dehydrogenase level, which is above the normal limit for the institutional reference range. Now, coming to the evolution manifestations that you see and subsequently the transformation to the blastic phase. The clinical manifestation when the patient initially presents to you is pronounced polycythemia. There is no blast, no or borderline anemia, no or borderline splenomegaly, and normal or borderline increased LDH levels. Okay, the manifestation, it moves on from reticulin deposition to collagen fibrosis and subsequently osteosclerosis. Right? So, patient moves on to have a decreased platelet count, okay, a leukoerythroblastic blood picture, okay, with progression of this fibrosis, and with anemia and splenomegaly and increased LDH levels. When we grade it as MF0, 1, 2, and 3. Okay, let's see the diagnostic criteria for overt fibrosis. In overt fibrosis, all the three major with at least one minor criterion must be met. So what are the three major criterions? The three major criterion are, one is same, we have megakaryocytic proliferation and atypia, but remember that it is associated with reticulin fibrosis in overt fibrotic stage. Okay, together with that, you have this BCR-ABL1 is negative, and the JAK2, CALR, or MPL mutation may be present. Okay, so it is either all the three major with one minor. So what is the minor criterion? We have anemia, we have leukocytosis, palpable splenomegaly, increased lactate dehydrogenase levels, and obviously we have leukoerythroblastic blood picture in primary myelofibrosis. So at least one has to be present, and that should be confirmed on two consecutive determinations. Okay, so this is a very important criteria. It must be confirmed on two consecutive determinations. Now, coming to reticulin fibrosis. When we grade it, we have either MF0 that I said, okay, that is associated with scattered linear reticulin deposition, MF1, with there is loose network of reticulin, okay, And you have MF2 with diffuse and dense increase in the reticulin network. Sometimes even focal osteosclerosis happens here. Okay, in MF3, on the other hand, you have a diffuse and dense increase in the reticulin with extensive deposition of reticulin, as well as there is dense osteosclerosis that is seen here. Now moving on to another case scenario. Now, if your patient presents to you with cytosis, okay, that is thrombocytosis this time, okay, and the bone marrow is showing a hypercellular bone marrow picture with panmyelosis fibrosis. Blast is less than 10%, okay, and the morphology of the cells are absolutely normal. So what do you think we are dealing with here? Yes, you are dealing with a case of essential thrombocythemia. So what is the diagnostic criteria? WHO says that all major criteria, or the first 3 major plus minor criteria, must be met. Okay, so what is the major criteria? The major criterion include platelet count of more than 4.5 lakh, a bone marrow biopsy showing proliferation mainly of the megakaryocytic lineage. Yes, you have hyperlobated nuclei here. The WHO criteria for BCR-ABL1 or CMLs, PV, ET, PMF, and other myeloid neoplasms are not met. JAK2, CALR, or MPL mutation may be present. Okay, and the minor criterion is presence of the clonal marker or absence of causes of reactive thrombocytosis. So, at least first 3 with 1 minor, okay, or all the major criteria must be met for the diagnosis of essential thrombocythemia. So this is the blood picture. You have platelets, a lot of platelets, but this does not mean anything. Let's move on. You have this thing, okay, you have the bone marrow. What does that show? Yes, there is megakaryocytic proliferation, and look at these megakaryocytes, okay, there's a lot of megakaryocytic proliferation here, okay. Now coming to this mega here that is shown, this megakaryocyte has a hyperlobated nucleus. Okay. Now coming to another case scenario here, you have a patient presenting to you with cytosis which involves the eosinophils now. Granulocytes done, we are done with CML, we are done with RBCs, PB, and we are done with platelets, that is ET. Now moving on to CEL. Yes, this is a case where you have an increase in cytosis, that is eosinophils. Okay, you have hypercellular bone marrow, panmyelosis with fibrosis. You have a blast which is less than 10%, and the morphology is typically no. So there is an eosinophilia. Okay, the BCR-ABL1, CML, PV, ET, PMF, CNL, and other causes are all not met. Yeah, there is no rearrangement of PDGFR-A, PDGFR-B, or FGFR1. That is the myeloid neoplasms associated with eosinophilias. They are not met. Blast count is less than 20%. Okay, and the inversion 16. Okay, AML inversion 16 is associated with eosinophilia. So even that has not been met. Okay, so that has also been excluded. And there is a clonal cytogenetic abnormality, or a molecular genetic abnormality, or a blast count of more than or equal to 2% of the cells in peripheral blood, or more than or equal to 5% in bone marrow. So this is the diagnostic criterion for CEL, or chronic eosinophilic leukemia, NOS. The histology shows that the bone marrow is hypercellular, okay, and you have a lot of hypolobated megakaryocytes. Look at these arrows here, okay. This is the hypolobated megakaryocyte. There are numerous eosinophils, which you can see, numerous eosinophils. Okay, these are all eosinophils which have been highlighted under high power. Now coming to the differential diagnosis of chronic eosinophilic leukemia. Yes, you have reactive eosinophilia that was covered in the last lectures. It may be due to parasitic causes, allergy, Loeffler's syndrome, skin, Kimura's disease. There may be secondary causes of due to lymphomas and systemic mastocytosis, or it may be an idiopathic hypereosinophilic syndrome. Now, what is that? Idiopathic hypereosinophilic syndrome is a condition where there is eosinophilia, that is, eosinophil count is more than 1500 cells per microliter. Okay, for longer than 6 months. That is also important. Okay. In addition, there is lack of evidence of any parasitic, allergic, or other known causes of eosinophilia. Presumptive signs of organ involvement, such as heart failure, gastrointestinal dysfunction, central nervous system abnormalities, fever, or weight loss, is also present. Okay, AML, MDS, MPN mastocytosis have been excluded. Even cytokine producing aberrant T cell population, okay, which results in lymphocytic variant hypereosinophilia, has also been excluded. So if these criteria, all of these criteria are met, okay, then this condition is called as idiopathic hypereosinophilic syndrome. Now coming to another case scenario. Patient presents with cytosis, okay, bone marrow is hypercellular, and the blast count is more than or equal to 20%, okay, and the morphology may or may not be normal. So what do you think it is? We move on to the most important myeloid neoplasm, and that is the acute myeloid leukemia. A clonal or neoplastic disorder of the bone marrow characterized by impairment of maturation in one or more myeloid lineages with accumulation of blasts in blood and marrow. So look at this. It's very important to differentiate a chronic myeloid leukemia, okay, from an acute myeloid leukemia. Yes, it's very important because there's a lot of granulocytic proliferation, but the granulocytes are in all stages of maturation. There's even basophilia here. Okay, the blast count can either be less than 2%, that is less than 10% in chronic phase. It may be 10 to 19% in accelerated phase, or more than 20% in the blast crisis. Okay, so, and this is a case of acute myeloid leukemia. What about this one? This one is a case of ALL. Okay, how do you differentiate a myeloblast from lymphoblast? And that everybody knows. The myeloblasts have open chromatin, whereas a lymphoblast has a clumped chromatin. Okay, and over here you have a lot of cytoplasm. Okay, the cytoplasm is quite scant in case of a lymphoblast. Okay, and there are approximately 2 to 3 prominent nucleoli that are seen in a myeloblast, whereas the nucleoli is rather very inconspicuous in a lymphoblast, maybe 1 or 2. This is again a case of AML. Note the monotonous increase in the blast population, and there is no maturation, no erythroid precursors can be seen here. So what do you think it is? Now, myeloblast or lymphoblast? Looking like a myeloblast, but this cell looks like having a very scant cytoplasm, right? But morphology, it's got an open chromatin, 2 to 3 prominent nucleoli, yeah, looking like a myeloblast. So when you are having that query, okay, what do you do next? We see orods. Yes, it is a clue. It's a good clue for myeloblast. But why? What is the need for the distinction? Distinction of ALL from AML is critical. Why? Because there's failure to treat appropriately at the initial induction may lead to failure to achieve an initial remission of the disease. So it's characteristically extremely very important to differentiate an AML from an ALL. Diagnosis can either be based on morphology, cytochemistry, but now what we basically need is immunophenotyping and cytogenetics. Now, cytochemistry. MPO, that is the myeloperoxidase, okay, which is also now used as an immunohistochemical marker, stains the neutrophil primary granules. Okay, it identifies basically the myeloblasts, which stain strongly positive, okay, whereas monoblasts are faintly positive. Sudan black B or SBB stains the myeloblasts strongly and monoblasts faintly. Specific esterase, or CAE for that matter, stains the myeloblast very strongly, whereas the non-specific esterase, or the NSE, stains the monoblasts very strongly. PAS, that is the per-iodic acid skiff, gives a block positivity for lymphoblasts. Pro-normoblasts and myeloblasts are usually negative for PAS. Okay, it is important to note that PAS stains your erythroblasts or normoblasts for that matter. So look at the stain here. We have the myeloperoxidase staining the myeloblasts. So this can give you a clue. Okay, in countries where immunophenotyping cannot be done. Okay, India was one such country. some time ago, but now we are well equipped with a lot of immunophenotyping coming up, and a lot of cytogenetics and even molecular coming up. So this is a SBB stain. Okay. What about this one? This is highlighting the monoblasts here. This is the non-specific esterase. Coming to specific esterase or chloroacetate esterase, now that is going to stain the myeloid cells or the myeloblasts, okay, and the monoblasts are weakly positive. Yes, so this slide has already been discussed, okay, with myeloblasts being strongly positive for myeloperoxidase, chloroacetate esterase, and Sudan black P. Now coming to the AML with recurrent genetic abnormalities. Now this is a very important type of AML which has been included in the WHO, okay, with recurrent genetic abnormalities. It involves T821, that is translocation 821, run X1 T1, AML with inversion 16, AML with PML RARA or T1517, AML T911, okay, AML with translocation 69, AML with inversion 3, and AML with translocation 122 associated with megakaryoblast phenotype. Other types of AML are AML with myelodysplasia related changes. We also have the therapy related myeloid neoplasms, AML not otherwise specified, myeloid sarcomas, myeloid proliferation related to Down syndrome, and we also have the blastic plasmacytoid dendritic cell neoplasm. AML with ambiguous lineage has also been added in the recent WHO, okay, and that includes the undifferentiated leukemias, mixed phenotype acute leukemias, MLL rearranged, okay, which has a monocytic phenotype, mixed phenotype acute leukemia, which is B myeloid, okay, that is it has a B cell and a myeloid phenotype, that is there is a B lymphoblast and a myeloblast, mixed phenotype acute leukemia, which is T myeloid, mixed phenotype acute leukemia, NOS. Now coming to that one by one. Now AML with recurrent genetic abnormalities 821, that shows a characteristic maturation in the neutrophil lineage. Note there is a maturation in the neutrophil lineage, and patients are usually young females. At presentation, they have a myeloid sarcoma. They should be diagnosed despite a blast count of less than 20%. Blasts have large azurophilic granules, or rods are very frequent, eosinophilic precursors may be increased, and it has a quite good response to chemotherapy. So even if the blast count is less than 20% here, okay, and the patient has a translocation 821, you have to diagnose that as AML. So the criteria for diagnosing an acute leukemia with a blast count of more than or equal to 20% according to WHO, okay, does not suffice when you have a case with T821. So look at this case here. This is a case of AML with 821. Maturation is seen in the granulocytic lineage. You have lots of granules. These are azurophilic granules in the cytoplasm, okay. Okay, even though blasts are less, yes, blasts are less, but the patient has a translocation. Okay, so you have cytogenetics and your molecular telling you that there's a translocation 821, run X1 T1. So if that is there, then you have to diagnose it as AML. How about AML with inversion 16? It has a lot of eosinophils. Okay, so increased abnormal eosinophils. Why do I call them abnormal? This is because eosinophils are negative normally for chloroacetate esterase. Okay, however, abnormal eosinophils of AML inversion 16, AML inversion 16, okay, is positive for chloroacetate esterase. So these cases are also diagnosed as AML even though the blast count is less than 20%. Patients with additional KIT mutations in such cases have a higher risk of relapse. Now coming to a very important acute myeloid leukemia, a very important topic for all the postgraduate trainees, acute promyelocytic leukemia. As you all know, this case is associated with a translocation 1517 or a PML RARA. There are two types. It's either hypergranular variant or a microgranular variant. Young adults or young females are usually affected, and patients usually have a disseminated intravascular coagulation. The microgranular variant has a very high WBC count and a rapid doubling time according to WHO. The morphology, as we know, yes, the cells have a bilobed or a kidney-shaped nucleus. Okay, look at this cell. Okay, this here. Okay, it has a bilobed or a kidney-shaped nucleus. What are these cells called as? Yes, they are called as the buttock cells. They have a lot of granules in the cytoplasm. Okay, and sometimes lots of OR rods. Lots of OR rods. When they have lots of OR rods here, okay, this is one, and there are several here. So what is this cell with several OR rods called? Yes, it is called as the fagot cell. Ultrastructurally, these OR rods are different from other AML. Why? Because these OR rods have a laminar periodicity of 250 nanometers instead of 6 to 12 nanometers seen in other types of AML. Cytochemically, yes, they are MPO and SBB positive because they are all myeloblasts, right? And now coming to the myeloblast equivalents, they are promyelocytes. Okay. Now coming to the immunophenotyping, they are HLA-DR positive, CD34 positive, which is a stem cell marker positive, CD11A, 11B, CD33, 13, 117, and 64 positive. CD56 expression in such cases is associated with a poor outcome. And obviously it is associated with translocation 1517. Now, retinoic acid receptor alpha, the RARA gene, is present on chromosome 17, and that fuses with the nuclear regulatory factor gene on chromosome 15, and that gives rise to PML RARA. But there are other variant mutations also associated with it, like the FLT3 ITD mutation. Now, these mutations are associated with microgranular blasts, okay, and have a very high WBC count, as I've already suggested that the microgranular variant is associated with a high WBC count. ZBTB16 and RARA mutation are associated with increased granules, absence of OR rods, okay, and strong MPO positivity. And there is even resistance to the ATRA therapy, okay, whereas STAT5B RARA mutation is also resistant to ATRA. Now coming to AML translocation 911, this is a condition which is associated with monocytic features. That is, the monoblasts and promonocytes predominate in this case. Okay, children are frequently affected, and DIC is the most common manifestation. As I've already said before, that the monoblasts or the promonocytes, for that matter, are positive for NSE, that is the non-specific esterase, and they are MPO negative. Okay, so when they're NSE positive, so that is giving you a clue that you're dealing with a blast with monocytic features. When you do cytogenetics, you find that there is a translocation 911 involved. And if you do immunophenotyping, you find that there is 4, 14, 11B, 11C, and CD64 positivity. What about this case? This is a case of AML translocation 6-9 associated with basophilia. Okay, so you have a lot of basophils here. Okay, look at this. Okay, this is a acute myeloid leukemia which is associated with basophilia. So basophils are more than 2% in the peripheral blood, and children as well as adults are affected, but it has a poor prognosis. How about AML with inversion 3? Typically very important. It is associated with an increase in the megakaryocytes. So increased atypical megakaryocytes in the bone marrow or peripheral blood can also be seen. There is a multilineage dysplasia. So inversion 3 is associated with dysplasia. Okay, as I said, the morphology can either be normal or abnormal, right? So the morphology was normal till now, but when we move on to AML with inversion 3, then the morphology of the cells becomes dysplastic. The immunophenotyping shows that it is CD13, 33, HLA-DR, CD34, CD38 positive. In addition, what is important is CD41 and 61 because they are megakaryocytic markers. Coming to AML with translocation 122. 122 is involved with Down syndrome. Yeah, but when you have AML with translocation 122, it's common in infants without Down syndrome. Dysplasia is lacking in this case. Okay. And blasts are usually of megakaryocytic nature. You have a lot of pseudopods that you see over here. A lot of pseudopods. Okay. So blasts are agranular. They have cytoplasmic blebs or pseudopods and no association with Down syndrome, unlike other AMLs showing megakaryoblast morphology associated with Down syndrome. That is the transient abnormal myelopoiesis. Okay. Now coming to the FAB classification of AML. The French, American, British, they classified AML as M0 or the undifferentiated acute myeloplastic leukemia, M1 or those with minimal differentiation, M2 with maturation, M3 acute promyelocytic, M4 myelomonocytic, M5 monocytic, M6 erythroid leukemia, and M7 acute megakaryoblast leukemia. Now coming to AML NOS. Now AML NOS is similar to what was classified by FAB. So WHO keeps the FAB classification intact, okay, and it renames it as AML NOS. So AML with minimal differentiation. So there is no differentiation evident by light microscopy or cytochemistry of myeloid nature. So the myeloid nature cannot be ascertained either by light microscopy or cytochemistry. Okay, so that is called as AML, which is minimally differentiated. Myeloid nature, how do you determine the myeloid nature then? By immunohistochemical markers or by immunophenotyping. They are HLA-DR, CD34, CD38, 13, 33, and 117 positive. Now, AML without maturation, where the blasts constitute more than 90% of the non-erythroid cells, okay, and cytochemistry shows that they are SBB or MPO positive, and they are CD13, 33, 17 MPO, HLA-DR, and 34 positive. So all myeloid markers positive: 13, 33, 17 MPO, HLA-DR, and CD34. How about AML with maturation? AML with maturation is when more than or equal to 20% blasts in the peripheral blood and or bone marrow are seen. Evidence of maturation of more than or equal to 10% maturing cells of neutrophil lineage. Cells of monocyte lineage constitute less than 20% of the bone marrow cells. So there is maturation seen in the neutrophil lineage in more than or equal to 20%, and monocyte lineage is less than 20% of the bone marrow cells. Then that is called as AML with maturation. Myelomonocytic, that is, there are two types of blasts. One is myeloid and the other is the monoblasts. So more than or equal to 20% blasts. The myeloid nature of the blasts can be ascertained by immunophenotyping using CD13, 33, 65, or 15, whereas the monocytic nature can be ascertained by 4, 14, 11B, 11C, CD64, and CD36. Regarding the cytochemistry, the myeloid blasts, or the myeloblasts for that matter, are positive for NPO, whereas the monoblast, promonocytes, and monocytes are positive for non-specific esterase. Acute monoblastic leukemia. Now, acute monoblastic leukemias are characterized by more than or equal to 80% of the leukemic blasts of monocytic lineage. So they are the monoblasts. Okay, they have somewhat a cleaved nuclei here. Okay, and sometimes they even have vacuoles within their cytoplasm. Acute erythroid leukemia characterized by more than 80% of the bone marrow cells, okay, and more than or equal to 30% of which are proerythroblasts. They are medium-sized to large-sized erythroblasts with round nuclei, fine chromatin, one or more nucleoli, and cytoplasm is relatively basophilic, agranular, and sometimes even contains vacuoles. Okay, it must be noted that these are PAS positive. Okay, so it is per iodic acid skiff positive. But MPO and SBB is negative. IPT shows hemoglobin A and glycophorin positivity. Now coming to acute megakaryoblast blasts. Okay, now acute megakaryoblast leukemia. Now this is a condition which is CD4161 positive, PAS positive. Blasts are more than or equal to 20%, of which at least 50% are of megakaryocytic nature. Look at this. You have a lot of cytoplasmic blebs or pseudopods here. Okay. Such leukemias or acute megakaryoblast leukemias are associated with the Down syndrome. Okay, but note that translocation 122 is not associated with Down syndrome. What about acute basophilic leukemia? Cytochemistry shows metachromatic positivity for toluidine blue. It is PAS positive. It shows positivity for CD13, 33, 123, 203, and 11B. However, it is negative for CD117, 25, and tryptase. Okay, so that helps in distinguishing it from mast cell leukemia, which is positive for c-KIT, CD25, and tryptase. So this is a 74-year-old woman, okay, who presented with asthenia, and you have a lot of basophils here. Look at the smear here showing a lot of basophils. Came out to be a case of acute myeloid leukemia with basophilia. Now coming to myeloid sarcoma, a mass consisting of myeloid blasts with or without maturation occurring at anatomical sites other than the bone marrow. Okay, so it should be at anatomical sites other than the bone marrow. Look at this picture. Let me just show it to you. Sorry. Yeah, this one. Okay, so it presented with an orbital swelling here. Now, myeloid sarcomas can either be de novo or they may precede or coincide with AML. The myeloid nature can be ascertained by the granulocytic markers, that is the MPO, SBB, or chloroacetate esterase. Myeloid differentiation markers like CD13, 33, 117 MPO may be positive. Monoblastic differentiation can be ascertained by CD14, 163, or 11C. And KP1 or CD68 is most commonly expressed marker for myeloid sarcoma. This is a picture taken from the New England Journal of Medicine. Now coming to myeloid proliferation related to Down syndrome. That is the transient abnormal myelopoiesis. The blasts are of megakaryocytic nature. Yes, they are CD41 and 61 positive. They have pseudopods, as you can see. Clinical feature is thrombocytopenia. Other features include cardiopulmonary failure, hyperviscosity, splenic necrosis, and hepatic fibrosis. Now, such cases, remember, undergo spontaneous remission. However, non-transient AML can develop in such cases after a period of 1 to 3 years. So, myeloid leukemia associated with Down syndrome is the one which usually arises after a period of 1 to 3 years after a transient abnormal myelopoiesis. GATA1 mutations have been associated with this condition. So trisomy 21 associated with Down syndrome with GATA1 is quite pathognomic of transient abnormal myelopoiesis. So children who are more than 5 years old have no GATA1. They are considered to be having a conventional AML or MDS, right? Mixed phenotype leukemia. Now this leukemia is characterized by a dimorphic blood picture. Okay, there are two types of blasts. Okay, that is myeloblast together with lymphoblast. It may be B myeloid or it may be T myeloid for that matter, or it may be associated with a monoblastic morphology as well. So there may be a MLL gene which is rearranged, which is associated with monoblasts and lymphoblastic population. Now coming to another case scenario. Now patient presents to you with cytopenia. Bone marrow is hypercellular. Okay, and the blasts are less than 19% and abnormal in morphology. What do you think it is? It is a case of MDS, that is Myelodysplastic syndrome. It's a clonal hematopoietic neoplasm that arises in the abnormal bone marrow stem cell. Usually characterized by normocellular or hypercellular marrow, but dysplasia is very important. Yes, morphology is abnormal, and ineffective hematopoiesis with blood cytopenia is characteristically seen. Blasts are often increased in number in blood and bone marrow. Let's see. Now, this is a very important chart. It's been taken from WHO. Okay, and MDS can be classified as MDS with single lineage dysplasia, MDS with multi-lineage dysplasia, MDS with ringed sideroblast and single lineage dysplasia, MDS with ringed sideroblast and multi-lineage dysplasia, MDS with isolated deletion 5q, MDS with excess blast 1 and 2, or MDS unclassifiable. Okay, when I'm talking about single lineage dysplasia, that means there's dysplasia seen in only one lineage. Okay, cytopenias can be either in 1 or 2 lineages, and the ringed sideroblasts are less than 15%. in blood or bone marrow and less than 5% when associated with SF3B1 mutation. Okay. Similarly, it may be associated with multilineage dysplasia, okay, where the blast count is obviously less than 5% in peripheral blood and or bone marrow. And with the ringed sideroblasts, when they are associated with the single lineage dysplasia or multilineage dysplasia, ring sideroblast as a percentage of marrow or erythroid elements are usually more than or equal to 15%, okay, and or more than or equal to 5% when associated with SF3B1 mutation. So it is very important to note that SF3B1 mutation may be present in case of myelodysplastic syndrome. Now, dysplasia, as I've already said, can either be dysgranulopoiesis, dyserythropoiesis, or dysmegakaryopoiesis, right? So dysgranulopoiesis may be associated with pseudo-Pelger-Huey anomaly, macrocytosis, chromatin clumping, hypogranulations, okay? Or it may be dyserythropoiesis, that is nuclear bridging, nuclear lobulations, multinuclei, cytoplasmic granules can be seen, or it may be dysmegakaryopoiesis, which may be micromegakaryocytes, okay, that is hypo or hyperlobated megas can be seen. Now, what is a ring sideroblast? A ring sideroblast is characterized by more than or equal to 5 iron granules encircling more than or equal to 1/3 of the nucleus, okay. This is a mitochondrial ferritin and stains with pearl stain. It is very characteristic of MDS. Now, coming to the chromosomal alterations associated with MDS, it can either be deletion 11q, okay, which has a very good prognosis, okay. There are some other deletions like 5q, 12p, 20q, which has a comparatively good prognosis, okay. Intermediate prognosis has been associated with trisomy 21 and trisomy 19, and also a monosomy 7 or a trisomy 8. And poor prognosis has been associated with a monosomy 7 and even a complex karyotype for that matter. Okay, very poor prognosis has been associated with a lot of complex karyotype. Now, coming to the differentials of MDS, now this is a very interesting article and it showed how we can differentiate different entities like the age-related clonal hematopoiesis, clonal cytopenia of undetermined significance, or for that matter, clonal hematopoiesis of indeterminate potential or the CHIP, idiopathic cytopenia of undetermined significance or the ICUS, idiopathic dysplasia of undetermined significance or the IDUS or the myelodysplastic syndrome. So how do you differentiate? When you have clonality with cytopenia and dysplasia, it's a case of MDS. Quite so. When there is only clonality present, okay, it could be age-related clonal hematopoiesis, or it could be a clonal hematopoiesis of indeterminate potential, that is CHIP. If it's only associated with cytopenias, it could be a case of idiopathic cytopenia of undetermined significance or the ICUS. If it's only associated with dysplasia, it could be idiopathic dysplasia of uncertain significance. If it's associated with clonality as well as cytopenia, but there is no dysplasia, in that case, it could be a case of clonal cytopenia of undetermined significance. So these entities very closely resemble MDS, okay, but however, they must be distinguished based on their clonality, cytopenia, or dysplasia. Now, coming to another entity, which is hypoplastic MDS. Hypoplastic MDS refers to a morphologic feature, okay, in which the marrow cellularity is low. That is, there is cytopenia in the peripheral blood as well as cytopenia in your marrow. Okay, that is, your marrow is hypocellular or rather hypoplastic for that matter. The cellularity is low, that is less than 30%. If the individual is less than 60 years, or less than 20% if the individual is more than 60 years. And this represents approximately 10 to 15% of the cases of MDS. Now, hypoplastic MDS does not represent a defined MDS category according to the WHO, but rather it denotes a morphologic status of other MDS categories, right? Nevertheless, patients with hypoplastic MDS usually tend to be younger. They have profound neutropenia, thrombocytopenia, lower percentage of blasts, and less likely to display abnormal karyotype in comparison to patients with normocellular or hypercellular MDS. Now, the prognostic significance of a hypoplastic MDS is very debatable subject. Okay, some say it has a good prognosis, the others say it has a bad prognosis. Okay, so quite debatable. The differential diagnosis is one of the basic differential diagnosis is aplastic anemia. So what are the features which favor hypoplastic MDS over aplastic anemia? Yes, the features of dysplasia, that is dysgranulopoiesis, dysmegakaryopoiesis, increase in the percentage of blast, and abnormal karyotype of SF3B1 mutation for that matter, all favor a diagnosis of hypoplastic MDS. In addition, an abnormal antigen presentation in marrow with CD34 positive cells, okay, and an elevated hemoglobin F containing erythroblast also suggests a hypoplastic MDS. Now, coming to our final category, where you have cytopenias, okay, and or cytosis in peripheral blood. Marrow is hypercellular, okay, and the blast is about less than 19%, and the morphology is abnormal. So what do you think this could be? Hypercellular bone marrow, okay, in a patient who is either having a cytopenia or a cytosis on peripheral blood, a blast count which is less than 20%, and the morphology is abnormal. What do you think it could be? We are dealing with the category of MDS MPNs, and the first three are very important. That is the chronic myelomonocytic leukemias, atypical CML, which is BCR-ABL1 negative, okay. Even though it is a CML, it is BCR-ABL1 negative, okay. And you also have juvenile myelomonocytic leukemia. So let's go into the diagnostic criteria. Now, WHO says that chronic myelomonocytic leukemia can be diagnosed when a patient has a persistent peripheral blood monocytosis. So it's a chronic myelomonocytic leukemia, which is associated with blood monocytosis. No Philadelphia chromosome, no PDGFRA or PDGFRB, okay, which is specifically associated with myeloid neoplasm with eosinophilia. And the blast count, as I said, is less than 20%. Okay, blasts can either be myeloblast, monoblast, or promonocytes, and at least one of the following: dysplasia in one or more cell lines. 1. 2 is acquired clonal cytogenetic abnormality or molecular genetic abnormality present in hematopoietic cells. Or you have a persistence of monocytosis for at least 3 months with no evidence of other causes of monocytosis. So if these criteria are met, that is all the 4 with at least one of the 5th criteria, then that is a case of chronic myelomonocytic leukemia. So this is a bone marrow aspirate smear of a patient with chronic myelomonocytic leukemia. Look at the monocytes are increased in number and the granulocytes are quite dysplastic, right? The erythroid precursors show a left shift and there's a megaloblast that you see right here. Okay. Now coming to atypical CML, or that is BCR-ABL1 negative. Criteria for the diagnosis of an atypical CML: it is associated with leukocytosis due to an increased neutrophils and precursors with prominent dysgranulopoiesis, right? So you have dysgranulopoiesis and a leukocytosis with increased neutrophilic precursors, right? There is no Philadelphia chromosome, no rearrangement of PDGFRA or B. Neutrophilic precursors, yes, they are more than or equal to 20% of the WBCs. There is a minimal absolute basophilia, which is approximately less than 2% of the leukocytes. No or minimal monocytosis, that is a monocyte count is less than 10%. So hypercellular marrow with granulocytic proliferation or granulocytic dysplasia with or without erythroid and megakaryocytic lineages, and a less than 20% blast in blood or bone marrow. So the picture is quite so similar to the CML that we see, right? But there is no BCR-ABL1. So this picture is quite similar to a CML, okay, but there is no BCR-ABL1. And in addition, there is minimal basophilia. That is, the basophil count is less than 2% of the leukocytes. Now, coming to another important entity, which is the juvenile myelomonocytic leukemia. The clinical and hematological features here are again a monocyte count of more than or equal to 1 into 10 to the power 9 per liter. Blast morphology is myelo and monocytic, that is, it is both myeloblasts as well as the monoblasts, but they are less than 20%. There is splenomegaly, there is absence of Philadelphia. Genetic studies show at least one need to be present, that is a PTPN11 KRAS or NRAS mutation. Okay, neurofibromatosis type 1, that is NF1 mutation, a germline CBL mutation. And for patients who meet the clinical and hematological features of the above but are without genetic features, the following criteria must be met. That is monosomy 7, hemoglobin F increased for age, myeloid or erythroid precursors on peripheral blood, and a GM-CSF hypersensitivity in colony assay, and a hyperphosphorylation of STAT5. So the clinical criteria, the genetic criteria must be met for a diagnosis of juvenile myelomonocytic leukemia. So this is a picture of a juvenile myelomonocytic leukemia. There are two types of blasts. One is the myeloblast and the other is the monoblasts. So eventually, when we conclude, what do we see? We see that the clonal myeloid neoplasms result from acquired driver and cooperating mutation. So yes, the genetic study is extremely very important. Within a multipotent progenitor marrow cell or a hematopoietic stem cell, translocations, inversions, duplications are all typically very important because they can result in either the expression of fusion genes, which may be PML RARA, STAT5B RARA, okay, ITB FLT3 mutations, the overexpression or underexpression of genes that encode molecules critical for the growth of cells. Okay, it can also result in the activation of the JAK-STAT pathway and increased transcription and proliferation of the cells of myeloproliferative neoplasms. And these somatically mutated multipotent cells from which the clonal expansion occurs of the neoplastic hematopoietic cell acquires the stem cell nature. Okay, so they start behaving like stem cells and then they start proliferating. And then what results is the myeloproliferative neoplasms, okay, like the ET, PV, or the CMLs, okay. And the next, we also have myelodysplastic syndromes and the MDS MPNs, that is the chronic myelomonocytic leukemias, juvenile myelomonocytic leukemias. So all these are the chronic malignant myeloid neoplasms, okay, whereas the acute leukemias may be either acute myeloid leukemias, which may either be AML with recurrent genetic abnormalities, or the AML NOS, or the myelodysplasia related AML, or the therapy related AML. A major change in the WHO 2017 was the inclusion of MDS MPNs, okay, and allowing for ascertaining the AMLs with recurrent genetic abnormalities to be included. The presence of germline genetic aberration should indicate a need to screen family members. So this is now coming up as a new tool, okay. Screening family members has also come up because ascertaining germline genetic aberrations to screen family members and make them healthy as well. So healthy family members diagnosed with leukemia predisposition syndrome should be counseled regarding appropriate cancer surveillance. The development of a globally adopted classification system crafted by the hematopathologists and clinicians has been a great benefit in the field of hematopathology. And it's quite a flexible and easily crafted classification, which is now being used by WHO. And it remains an effective instrument for daily therapeutic decision-making and clinical trial designing, and will also inform for any further future classification schemes. So we need to add even more and go into further targeted therapies in case of acute myeloid leukemias. So thank you so much for your patient hearing. It was a very long seminar.
No, it was not at all long. It was very relevant and very nicely done. Thank you so much, Dr. Shristi. Very well done. You really worked hard in trying to compile this topic. The topic itself is very long. It encompasses a large aspect of things. So very well done. Brilliant, actually. and almost
Thank you so
everything
much,
has
sir.
been
Thank you.
covered, and the relevant areas have been covered in much detail. So it's so important. Thank you so much.
Thank you so much, sir.
Please do remember to. Dr. Manoj Gupta says very informative. Thank you.
Thank you. Thank you,
Uh,
sir.
please remember to share the PDF. We'll upload it. Right.
Yes, sir. Yes, sir. Yes,
Right.
sir.
Thank you, Dr. Shristi, for taking out time. Thank you. Bye bye. Take care. Good. God bless you. Good night.
Thank you. Thank you so much, sir. It was an honor, sir. Thank you.
Thank you. Bye.
Bye bye. Good night.